we are saying that one of the things that we need to do, our first recommendation, is to try and improve the data we're collecting on individuals, which then feeds into the National Lung Cancer Audit. So that the National Lung Cancer Audit becomes much richer, and not just at an individual basis, but in sort of groups of people, as I've said. And then we can see, if there are common themes and, how people are potentially disadvantaged. So we have the National Lung Cancer Audit and improving that information, and also the holistic needs assessment. Each person who's referred will have a holistic needs assessment completed about them. Although there are templates for holistic needs assessments, again, we think the information we collect could be a lot more detailed. And that process could start at the time of referral in primary care and then follow the patient through their journey, being added to and annotated, rather than being started, as often happens in secondary or tertiary care. If people coming in, we have that information. For instance, their first language is not English, that they may have not be able to read and write terribly well, that they are of no fixed abode, or from a travelling community, and contact may be more difficult. There are lots of very small, subtle points that can make a huge difference to how we can help people. And these things often come out during the patient journey, and you realise actually there may been an issue that we should have addressed earlier on. And I see this in my own clinical practice quite often. Things come out that you think, we should have, it would have been useful if we'd known that at the outset. We can take this information from the National Lung Cancer Audit and the holistic needs assessment and have a sort of much richer data set, a combined data set, which can then feed into the other demographics and information about people. And essentially, one of the ideas we could develop is that patients have essentially a health needs card that they could potentially carry with them, in the same way that ladies who are expecting have a maternity card that they can take from one hospital to another. We could do and develop a similar thing around health inequalities, because one of the things that we know is that patients going through a cancer pathway often may have their care in several different hospitals. So they may be seen for instance, a district hospital. They may be referred to a tertiary centre for investigations. They may have scans in other hospitals. They may then need chemotherapy or radiotherapy or lung surgery, and that might be done in a different centre again, and then maybe referred back to their original referring local hospital afterwards. So people move around in their journeys, and we need that information to follow them, because whether we like it or not, many hospitals don't have terribly integrated data systems and IT systems, and these different trusts don't talk to one another from the data point of view. And this might be one way of improving the transfer of information, if patients had their own information which they could carry with them and show people as they go along. We also, in order to mitigate some of these inequalities, so the first thing we're saying is we need a lot more data on inequalities, and we need to better understand these issues for people. But then thinking about mitigation and bridging the gap, as it were, what can we do? There are things that we can address fairly easily. There are other much bigger social issues that will have to be done at governmental level. But we very much endorse and support the CT screening programs. We've been calling for CT screening for detection of early disease for a long time. And we're delighted, as I said, the National Screening Committee has made their recommendation, and we hope that governments of the 4 nations will support that and drive the CT screening programs forward. We've also got to have continued smoking cessation work and the disease awareness programs. These are really important. Again, reaching out into different communities in appropriate ways, because how you approach different people coming from different community backgrounds will potentially substantially affect how they look at that information and how they engage. Having information written in an appropriate way, an appropriate level for their interpretation, and obviously in appropriate languages. So very much more tailored to individuals. And of course, it's people working locally who know their own patch, as it were. They know the different communities and populations in their local areas, particularly lung cancer nurse specialists who often are local, have been doing the job for a long time. They know the local populations very well. So these are the sort of things that we think we can improve. Sometimes it's things like the distance from a person's home to the hospital. They may not drive. They may not have anyone who can take them. Or we've got to facilitate transport more. Childcare, single parents may have someone they can call upon once or twice to look after the children, but if they're going through a course of treatment, that may be very difficult. So again, we need to look at all these various steps, all the barriers that may cause these health inequalities for individual people. So that is the essence of the report and the reason we've written it, because we really want to raise awareness of these many issues, and by doing so, improve the care for individual patients and individual and different communities. There is an element of we don't know what we don't know at the moment in some of these areas, and I think if we have a much richer background information data, then we will probably find things that we didn't realize and be able to make changes. And it may be quite subtle things on an individual basis, but what might seem like a small thing to us could make a huge difference to that individual person. And trying to improve outcomes for patients, often measured in terms of survival, is not just the big things. It's often the little things and the attention to detail.